Thank you.
Thank you.
Thank you, Dario. Good evening, everybody. The purpose of my talk is to speak about 3D and 4D of the fetal heart, technique and potential. I just have to say that now 3-dimensional and 4-dimensional ultrasound have been proposed for several years, nearly 20 years ago now, as being considered as valuable tools to obstetric imaging. When we see this slide, we can see the evolution of the 3D and 4D imaging through the age or through the time, and we can see that at the beginning of the 90s until now, there is a tremendous improvement of the quality of the picture, especially based on the faster acquisition, on the automatic acquisition doing by the probe, as well as by the quality of the rendering modes, of a lot of modality and algorithm calculator by the process, and as well as by the robustness of the processor. Just before to talk about this topic, we have to define what is a volume. What is a volume? A volume, it is by definition, it can be simply considered as being an additional of infinite number of 2D plane, whatever their spatial organization. Here we can see on this slide that the fetus are being a volume acquisition of the whole body, and here the representation of this volume. On the next slide, we can see that the addition of different things, especially, too quick, we simulate here an acquisition of a volume considering the region of interest, the fetal heart, and we can see different number of slices, and this addition will make at final a volume. Then we can consider that a volume, whatever the size, the shape of this volume, is an addition of different kind of planes, especially planes that are usually every parallel. When we speak about this topic, the main goal is to try to improve the pickup rates of congenital heart disease. Why? Because the fetal heart is a very complex structure anatomy. The baby is moving, the heart is moving, and the heart anatomy is very difficult to assess. And then the main goal was initially to try to improve the detection rate of congenital heart disease by this technique, by decreasing the dependency of the skilled operator using 2D dimensional ultrasound. Why this topic? Because it is well demonstrated now, especially for transposition of great arteries, that prenatal diagnosis of such kind of disease reduce significantly the mortality and the morbidity rate of such infants. When we have to speak about 3D and 4D imaging about the fetal heart, we can divide this modality into two groups. The first one is what we call non-gated. Non-gated is when we have to make an acquisition of the fetal heart without considering the movement, the motion of the fetal heart. This modality has some advantages and as well disadvantages. Advantages that the resolution is very high, the acquisition time is very, very, very fast, very speed, but we don't have any information about the movement of the valve and the structure and the dynamic process of the heart. And then different modalities have been then introduced, especially what we called gated imaging. It's possible with some manufacturer to have this imaging in real time. It's what we have using linear matrix probes. And then different kind of algorithm had been proposed and introduced by different kind of manufacturer to have post-process the rendering of the acquired volume, and then what we called spatio-temporal image correlation. Now, for my lecture, I will to develop this topic because it's probably the most well implemented worldwide. Here we can see the two representation of what is for example, here real-time 3D of the heart, and here it is offline after processing, after an acquisition. You can see that theoretically this picture will be a very good idea, but nowadays, the spatial resolution of this probe is not very high, not very sufficient, but it's probably the future of the fetal heart imaging, considering the volume. Then I will develop STIC. STIC is a technique that allows acquisition of the fetal heart volume and visualization of cardiac structure as 4D cine sequence containing a lot of information. While a complex process is describing, we have to try to make a very easy task about STIC. What we know about STIC is that the process will make an average of systolic peak of the fetal heart, make an average to calculate the fetal heartbeat, and then to reconstruct afterwards an entire cine loop of the fetal motion. Here, we represent what means exactly a STIC volume. We have to consider at first here what is the reference plane. The reference plane is defined by two-dimensional features, the width and the height, and the corresponding plane in the spatial organization. The width means the X planes, the height is the Y planes, and the depth, that means the depth of the volume, it is the Z planes. At first, when we want to make a volume, we always to keep in mind that in order to obtain a good volume, we have to make a good acquisition, and then just before to make a good acquisition, we have to optimize our 2D RS examination. It's why it's a little bit funny when we say at the beginning of this topic that initially this field was to try to decrease the dependency of the skill of the operator, but just at here, it's possible to say that different kind of things will probably interact with the quality of the volume acquisition. At first, the 2D settings, then the quality of the acquisition, and then both of them will together have consequences on the quality of the volume rendering. So I move to the next step, is how to acquire volume. That is the answer of my topic. At first, we'll try to optimize the 2D things. That's what we use in a clinical way every day in order to optimize our examination of the fetal heart. As Dario and Julien said just before, we have to narrow the transducer, then we have to place at the correct place the focus, we have to decrease the depth of the region of interest, and then we can see here that there is a very high frame rate, 85 Hertz. That's the initial step in order to try to obtain a good volume. It is very mandatory. Then the next step is to keep in mind what region of interest will we examine. We have to narrow the ROI, what we call region of interest. Here we can see an acquisition. Different kind of things can interact with the acquisition. At first, when the ROI box is very narrow, you will try to decrease artifacts of the baby movement, artifacts of mother movement or bracing. It's why to tailor the ROI box is very important. This is what we call the region of interest. Then other features will probably interact with the quality of the volume. It is especially the acquisition time. You can set the acquisition time of your machine. You can choose from 7.5 seconds to 15 seconds. Here we can see the same volume, and within the same volume you can choose to have maybe, for example, 4 planes, or for example, a lot of planes, and whatever, this is the same depth. Whatever the depth, if you have 4 planes or 15 planes, there is not the same time of acquisition, and there is not the same time of quality of high resolution. If you choose, for example, 15 seconds, you will have a very high definition, very thin slices to each other, but you will be subject to interact with artifacts. The other things is you can choose and you can modify what we call the acquisition angle. For example, when you make a 4D ultrasound volume of the heart, of the fetal heart during the first trimester scan, you have to choose very, very low, very narrow angle around 15 degrees. For example, during the second trimester, nearly 20 degrees, and during the third trimester, 25, nearly 30 degrees. And the width and the depth of this angle acquisition will also interact of the quality and may be subject of artifact by the mother or by the child. Then, when we make the acquisition, this acquisition will take after a few seconds, what we choose just before. We define here 3 orthogonal planes, and we can see here, this is what we call the reference plane. The reference plane is a plane what we choose initially to make your acquisition, and you can see on this slide that the resolution of this plane is similar as 2D conventional ultrasound. Then the 2 other orthogonal planes, the B plane and the C plane, just there, have lower resolution. Here we can see what means exactly the depth of the angle of acquisition. Initially, the 3 orthogonal planes are static. Then you can choose to integrate a dynamic process by activate the cinematic ability, and you can choose to describe a cine loop, the entire cine loop of the fetal heart. In which mode it is possible to display this volume? Different mode and algorithm has been proposed by different kind of manufacturers. I will try to make an overlap, an overview of all these modalities. At first, it's possible to have a single 2-dimensional or multiplanar orthogonal displays, what we saw just before. And just afterward, I will detail what mean exactly multiplanar tomographic ultrasound imaging. Here we can see I choose voluntarily to have only one plane on the screen, and by scrolling through my volume dataset, it's possible, such as Julien said just before, to make the virtual sweep. It's virtual sweep of the target anatomy region of the fetal heart. You make an acquisition. This acquisition is made automatically by the transducer. You choose the spatial orientation of your acquisition, and then it's possible by scrolling within your volume to displace your region of interest from the lower part of the heart, from the cetus, from the fourth chamber view, from the left ventricular outflow tract, the right, and then the free vessel view. The resolution is not very good, but it's fine. It's very important to show that whatever the quality of the resolution, it is not very as high as possible, but it's very relevant and informative. Now I have no only one plane, but 3 orthogonal planes. And by such modalities, it's possible to use different kind of algorithms that are proposed by Goncalves and Mr. Abouhamad as well. And in order to assess in a systematic fashion the fetal heart. For example, you have to turn around the x-axis in order to put the apex on the left side, to put the thoracic aorta on the left side. Then you can turn a little bit. You have to punch your dot plane just here, move a little bit on the median on the septum, and then you have to turn around, and you will display now the left ventricular outflow tract. You can see just here, we can see the mitral continuity, you can see the septo-aortic continuity, and here you can see just afterwards, I hope so, the right ventricular outflow tract. This is algorithms that are very and well demonstrated and explained in different, in a very rich literature. Then the next slide is to speak about always how to facilitate the assessment of the fetal heart, always to try to increase the pickup rate of the CHD. Simcha-Hegel proposed several years ago to facilitate the fetal heart examination. Julien has said before, Dario as well, and I will try to explain a little bit more. You can make 5 slices, 5 parallel slices. You don't have to tilt up a little bit on the upper side, on the left side, on the right side. Just only make parallel slices like a sweep. For example, you can see here the sweep of the fetal heart, but it's difficult for you probably to show what I done with my transducer. Then I'm going here with the slide. We can see here there is only vertical plane, parallel vertical plane, tangent. All plane are displayed here. Here from this picture, we can see here the initial part of the fetal examination, the situs examination. It is the stomach on the left side, the abdominal aorta, the inferior vena cava. Then you can move to the next step and you can choose the distance between all the slide, and you can choose always the number of the slide that you want. Here you can have a 4-chamber view, very, very relevant and informative. Then to the next slide, you can move on millimeter by millimeter, and here you can see that I choose 1.5 millimeter between every slices. Then we have the left outflow tract, the right outflow tract with bifurcation of the pulmonary artery, and then you will have the free vessel and tracheal view. It's very important to understand what I mean, because here you understand that the fetal examination can be done only by tangential examination, only parallel examination. There is no tilt on up, there is no tilt on the left or on the right. Only make a sweep, a parallel sweep. Then you can put color and color Doppler in order to increase the information, but we can discuss just afterward during the discussion session if it is relevant to put Doppler in the systematic way when you have to screen a low-risk population. And you have also the 4-chamber view, you have the left outflow tract, the right outflow tract, and then the free vessel and tracheal view just there. Then, after I describe how to display the acquired volume in 2 dimensions and different kind of orthogonal planes, I will now explain a little bit how to display in rendering mode. What means exactly rendering mode? Rendering means that we try to display external or internal parts of the target anatomy of the acquired volume. There are different algorithms: surface mode display, transparent minimum mode, invert mode. You can combine all this mode with color, power Doppler, HD flow, B-flow, and I will try to show you in which situation it can be assimilated as an additional tool. Here we take the previous slide, and what is the difference? We put just here what we called the rendering box. Here, this is a rendering box, and the gray line means that we want to view the area of interest from above, from here. This is a rendering plane, whatever the algorithm that you choose. You can put a dynamic process as well. What is very important that initially you have to thinking about what you want to show and to assess. You can initially put your gray line, your view plane, what we call the view plane, just just here. You can change, and there is another possibility. You can put your gray line just here, and whatever your position, the rendering will completely different. First example, when I used surface mode display, for very nice, but we can increase and we can enhance the contrast between the myocardium, the valves, and the cavity, especially the left ventricle, the right ventricle. We can see the offset of the AV valve. We can see also a little bit more than here the primary septum, the secondary septum, and the valvular obviescence. Another plane that is very, very slicky is to make a rendering, to put the rendering box just there with a gray line just in front of the AV valve within the ventricular. And then you can see that there is like a surgical view of the AV valve. You can see here, I don't know if it's possible to show with a good resolution, but we can imagine that here this is a tricuspid valve with three valves, and here only 2 valves. There is a mitral valve. It will be especially interesting to make this view when you have AV canal. So another view when we used the surface mode is to put like a camera towards a region of interest. Now, for example, I want to assess how looks the septum from a left lateral view. I can make a translation like a sweep, but afterwards, this sweep, I've made an acquisition, and you can control that the integrity of the septum. When you have, for example, in this slide, a doubt about VSD, it's possible you have to turn around. Naturally, you have to turn around. I don't say that 3D will always be the solution, but in some way, it will be helpful. Here we can see the interventricular septum. Here this is the left outflow tract, and here you can see the VSD, the outlet VSD, in the perimembranous region. You can see here with a dynamic picture. Other mode in which we combine, for example, here this is the interventricular septum. You can try to imagine, because this VSD was picked up by conventional 2D when I had a color Doppler. You can see a very small hole, and here when I put the color Doppler, it's possible to highlight it very well. Other mode, I think it's a little bit difficult because there is, I have to use it, and Rabbi Shawi and Dario Palladini introduced this view, a very nice view, in order to understand what means exactly, considering the spatial organization of the AV valve, especially the main vessel raising above the ventricles. In the normal fashion, you have here, this is a coronal plane, it is a frontal view of the heart of the baby. Here, this is the left side, this is the right side, here this is the diaphragm, and here will be the head of the baby. Here you can see at first it is the aorta, and then just above it is a pulmonary artery. This is a normal organization and distribution of the vessel. It is what we called normal en-face view of the main vessel. In some pathology, especially artery malposition, transposition of the great artery, we will check afterward how it can look. Here, for example, in 2D, it's also possible to make this view, but it's a little bit difficult. And in my experience, in my point of view, it's easily to have this view from 26, 24, 28 weeks of the gestation, especially during the end of the pregnancy. But at the beginning, it's very difficult because leaflets are very thin. It's not very easy to show. Here, for example, you can see the coronary artery, one here, and the other part, the root is here of the coronary artery. I don't know if you can see, but in some instances it's possible. Here, Dario shows that just previously. For example, in the normal fashion, you may have mitral, tricuspid, aorta, pulmonary artery, and then when you have transposition of the great artery, we know that it's possible that the main vessel can turn around each other in different fashion, like a clockwise, and it's possible to be side by side, upper and down. For example, here it is a normal, and here it is a corrected conjugated transposition of the great artery, and we have a completely switch of the main vessel. Here, in the normal way, it is the aorta, and in this side, it is the pulmonary artery and the aorta. Then I moved to the next mode, the transparent minimum mode. I just show you because it exists, but I don't think that it will add relevant information. Here we can see that main vessel raised in a parallel fashion. It is a classical transposition of the great artery, and you can enhance the contrast between the anechoic spaces within the ventricle and within the main vessel, and by blurring all the surrounding structure. And here it is another example of DORV, double outlet right ventricle. Here this is the left ventricle, the right ventricle. This is the aorta completely on the right side. And this is the main pulmonary artery with an overriding of the septum, and it's what we call the Taussig-Bing DORV. Another mode that is very slicky as well, especially in some pathology, what we call the invert mode. The invert mode is theoretically to voluntarily choose to enhance what usually is completely anechoic and to make a shadow on the surrounding structure. Here is very gross anatomy. It's difficult to show and to find anything. But when you have to go to your different mode to put a different kind of algorithm, and then it's possible, for example, to show the arches, especially when you suspect an anomaly of the arches, anomaly of the position, anomaly of the size. It can be helpful as well. B-flow mode, very interesting mode, because this mode is a Doppler mode who is specifically independent of the angle of the insinuation. Dario highlighted previously very well that the quality of the Doppler is supported by the tangential insinuation of the region of interest. But this mode is completely different. Whatever the orientation, especially for very thin vessel, especially pulmonary veins, it can be very relevant and very informative. How to assess the crisscross of the main vessel? I will show you different mode, how to obtain this information, especially when you have to say in the setting of the screening of the low-risk population, you have to be nearly 100% confident that there is no transposition of the great artery. Why? Because whatever the fact that there is a very uncommon abnormality of the cryotap, in nearly 5% of cases, the baby can die within the 10 minutes after the delivery, and it can be lawsuit, especially in this situation. For example, you can choose different mode: invert mode, color mode, power mode, B-flow mode. All this mode, I'm just saying that it is complementary tool as 2D. And initially, when I use my algorithm to demonstrate this crisscross of the main vessel, and when I have some difficulties, possible to add another feature to try to better understand what it means exactly. Okay, for example, here it is transposition of the great artery with invert mode. It's possible to say the parallel fashion. Here in minimum mode, here in invert mode. I will show you a little example. Here in DORV, it's possible to show the very extraordinary pathway of the aorta, completely on the right of the pulmonary artery. And here we can see like a digital cast, what happened exactly in this specific malformation. Here, for example, another anomaly that is maybe in some instance very critical, especially when you have coarctation. You can see here with the anatomical correspondence that here it is a normal shape of the of the descending aorta. You can see here the ductus arteriosus, here the aortic isthmus just after the left subclavian artery, and we can see that in normal fashion the descending aorta is just going after the aortic isthmus. But when we suspect, when you have unitero coarctation of the aorta, some baby will have this kind of fashion that Jolene described very well previously some years ago, that we called like postnatally a shelf indentation. You can see that here in coarctation the descending aorta is coming just after the ductus arteriosus, and here it's like a step. You can see like the correspondence. Interruption of the aortic arch is always impossible to show what it means exactly. Here, always very, very nice to show what happens, especially in the setting of anomaly of the aortic arch. Here you can see the disposition. The yellow dot means it is the position of the trachea. Here this is the left, the right, the anterior part and the posterior part. And you can see here the left outflow tract going on the right side of the trachea. Here we can see a very uncommon situation of a double aortic arch with the right arch larger than the left one. That is a usual situation. And here, what Rabbi described very well some years ago, what we call now a very interesting thing, the right subclavian, abnormal right subclavian artery. Another mode to understand how it looks, Rabbi Shawi described that in some situations it's possible to show 4 vessels arising from the aortic arch, and when you suspect and when you make your sagittal view of the aortic arch, when you're able to show this 4th vessel, in some instances it's possible to have an ARSA, but in other situations ARSA can be displayed in this condition, very far from the descending aorta in this manner. You can see just here the frontal representation. Maybe the last example of tetralogy of Fallot to understand in which situation 3D and 4D imaging can be helpful. Here we can understand, I remember that Jolene teach me how the physiology of the tetralogy of Fallot. We can see here that the very large aorta, overriding aorta, is filling as well by the left ventricle and by the right ventricle. There is 2 filling by both ventricles. Then you can confirm that by using the previous mode, and you can see an overriding aorta, but just with this picture is not sufficient to be sure that it is a tetralogy of Fallot. And then here, for example, is very interesting because we can see here what can add a very relevant information, especially in the concerning of this malformation, because what we have to show is how looks the pulmonary artery, the main pulmonary artery, the main pulmonary branches, and then if it is backward, forward, or anterograde flow within the ductus arteriosus. And here, in this situation, the pulmonary artery looks very well, the pulmonary roots are very fine, but here in this situation, the ductus arteriosus have an abnormal situation, usually always under the aorta, and you can see the retrograde flow, the backward flow just here. Okay, just now my last slide. I remember that now nearly 10 years ago when I saw my first lecture about 3D. It was in 2003 by Rabbi Shawi in Paris. And I remember that the audience was completely crowded. And at the end of the lecture, people are going outside of the audience, and a lot of people say it is fireworks. And for me, it is always the same finding, because the time elapses, but the interest remains and becomes stronger and stronger. And I hope that with this lecture, I help you a little bit in order to try to understand a little bit more how works 3D and 4D imaging of the fetal heart. And I hope that this modality is less daunting for you. And then finally, I invite you to download this very nice paper that you can freely download on the White Journal website by Romeo. And I hope all is well for you. Thank you for your attention.